Everybody hang on a minute. We'll be going live momentarily. Just want to let everybody come in. Okay, let me turn it over to Diane Quinn, who will be moderating our session this evening. Thanks, Diane.
Thank you so much, Glenn. Good evening, everybody, and thank you so much for joining our panel. The connection between housing and homelessness is generally intuitive. Unfortunately, the link between health and homelessness is often overlooked. We really don't know what other people are going through. Per the National Health Care for the Homeless Council, people in the US experiencing homelessness have higher rates of illness and die on average 12 years earlier than people who are housed and in the same age group. The life expectancy of an individual experiencing chronic homelessness is about 48 years old. The incredible instability, the lack of secure and stable housing, the lack of healthy food, no income, inconsistent health and inconsistent hygiene and access to toileting impacts the physical and behavioral health of a person experiencing homelessness, making it nearly impossible for them to remain healthy. The National Alliance to End Homelessness reported in December of last year that Washington has the highest rate of homelessness in the United States. We have 9.3 people of every 1,000 DC residents who are experiencing homelessness. This is higher than New York City, which is second with 4.7 homeless people per 1,000 residents. How is homelessness defined? In the United States, a homeless individual is someone who lacks a fixed, regular, adequate nighttime residence, someone who lives in a shelter or a place not designed for human habitation, or a person fleeing from domestic violence who lacks a source of permanent housing. Homelessness can come in many forms. People live on the streets, in encampments or shelters, in transitional housing programs, or doubled up with family and friends. This evening, our panel will explore the links between health and homelessness and share that perspective and experiences that they have personally had with direct care to homeless individuals living in the District of Columbia. Let me briefly introduce our committed and distinguished panel. Dr. Sarah Myers is a family physician with Unity's Healthcare for the Homeless program, and she resides in DuPont as well. She practices at Unity's Upper Cardoza Community Health Center, and on Wednesday, she provides medical outreach in the DuPont area. Dr. Myers is also trilingual. Dante Nukotara is a unit clerk at Christ House. Christ House is a medical respite facility for homeless men in Washington. Dante oversees the logistical aspects of patient care, such as scheduling medical appointments and processing medical orders for men who are recuperating from surgeries, hospitalization, and significant ailments. Dante is a graduate of Catholic University, graduated in May of last year, with a bachelor's in biology and neuroscience. Dante is going to medical school this July. Another of our panelists is Jordan Gully. She's a licensed clinical social worker who is a site coordinator with the DC Department of Behavioral Health. Jordan's team is a 24-hour, 7-day-a-week multidisciplinary team that works with individuals experiencing emotional, psychiatric, and substance use vulnerabilities. Jordan has worked in DC mental health and homeless services for 10 years. She's also the co-chair for the Outreach Policy Work Group for the Interagency Council on Homelessness. Our fourth panelist is Leah Lyons. She is the DC Homeless Outreach Social Worker for the Department of Veterans Affairs. Leah has over 13 years experience working with this population around DC, Maryland, and Northern Virginia. Leah previously served as an assistant director for the Montgomery County Coalition for the Homeless, which is a veteran safe haven program for short-term, 24-hour, 7-day-a-week residential transitional housing. Leah has collaborated and guided local and grassroots agencies on best practices such as trauma-informed care, harm reduction, and housing first models. We'll start this evening with Dr. Myers. Sarah, the National Healthcare for the Homeless Council states that homeless individuals have a heavy burden of medical and psychiatric illnesses, co-occurring medical illnesses, psychiatric problems, and substance use disorders. Please share the impacts of being homeless on the health of an individual, and how does living on the street impact chronic health conditions?
So first off, thank you, Diane, for organizing and for bringing us all together to talk about this. My name is Sarah Myers. I'm a family physician with Unity Healthcare, primarily with our Healthcare for the Homeless team. I've worked here for about 3.5 years, and I live at 22nd and Q, so I'm in DuPont Circle. I grew up in Potomac. I considered it the most boring place I could be, so I ended up somewhere that's a little bit different. And probably I live here for the same reason a lot of our homeless neighbors live here, that there's lots of food options. It's convenient. It's easy to get to work from here. And friends of mine are here. People I care about. My social network is around here. And I think for both our housed and unhoused neighbors, folks are, and it's just a safe and comfortable place. A couple things I've noticed about my patients who are homeless and their health. I've sometimes been asked which comes first, the homelessness or the health problems, and the answer is both. They both come first. It's usually a spiral of events. It's usually more than one thing. Occasionally it's one catastrophic thing, but usually it's a snowballing of events. For the majority of my patients, they often aren't quick to talk about their childhoods, but when they do, things did not go well, disproportionately, just very severe adverse childhood events, early parental loss, parental addiction, childhood sexual abuse, often more than one thing. Sorry, my apologies for my guard dog there. But where was I? So there's often a number of vulnerabilities. Like if you think about it for yourself, if you became ill, if you lost your job, what would your network be? For a person to become homeless, something has happened to that network that would catch them, that the family was somewhat very low resources, mental health problems, frayed relationships, abuse, some multiple things have gone wrong. For many patients, physical illnesses or injuries get in the way of their employment. For a lot of people who have less education, if you start having back and hip and knee problems, you are out of a lot of the jobs that are available for you. A lot of patients end up underperforming at their jobs and losing their job due to a sort of quieter burden from chronic illnesses. I'm thinking of a patient of mine who turned up, worked at a job for the city for about 20 years and lost her job a few years ago. And we found out shortly after she made her way to our homeless clinic that she knew she had diabetes, and the diabetes was out of control. She also had HIV, which she didn't know, that had gotten somewhat severe. And I don't know if it's how she lost her job, but it's not uncommon when we see people with chronic illnesses that there's a fair amount of fatigue, of brain fog that can come with those, that can make it hard for people to do their jobs. Other things that we see, people with cognitive struggles, for example, people who had learning disabilities or intellectual disabilities diagnosed or not diagnosed, but there during childhood, they are disproportionately more likely to be homeless. People who've had a traumatic brain injury, I imagine the VA sees a certain amount of that, but also just people who experience TBIs in the rest of their life. Let's see what else. Older folks with strokes. We see a fair amount of people who they lived a normal life, had a family, and maybe never had children. Maybe their spouse passed away. They have a stroke in their 50s, their 60s, their 70s, have some memory losses, cognitive losses, and disproportionately can't manage to pay the rent, don't know where their checkbook is, don't know where the rent goes after that, and end up homeless, which is a really heartbreaking subset of it. Certainly mental illness is disproportionately related, and to be mentally ill and trying to apply for disability for yourself for that is really not a functional process. So for a lot of people, it is just so hard for them to get the benefits that they need, because if you look at them, you wouldn't hire them for a job. They're not going to be able to do that. But then when they're homeless, their case manager can't find them. So it's really hard for another person to break that cycle. We really don't have a good safety net for people there. History of
Dante,
incarceration.
I was going to say, Dante, is this your experience as well? You are at Christ House, and you are a respite facility for men who are experiencing homeless that are ill. Please share your experiences.
Yeah, certainly. I mean, just building off of Dr. Myers, you know, for Christ House, just a little bit of background, we serve men who are experiencing homelessness. And our two criteria is if they're not a DC resident, they have to be able to become a DC resident. So that way we can get them insurance. And then the other criteria is they have to have an acute medical need going on. And so what that normally looks like is we have a lot of guys who are coming to us from the hospital after just having had surgery. That could be anything from hernia surgery to maybe they were hit by a car and needed surgery on their leg. We also see patients who have cancer or uncontrolled diabetes, or they might have a really bad wound that just needs wound care to, you know, get them back on their feet. But definitely reflecting, you know, what Dr. Myers was talking about, almost all of our patients have chronic issues going on as well. While our mission is to serve and treat the acute needs going on, the percentage is 75% of our patients have 3 or more medical diagnoses. So 3/4 of our patients have, you know, lots of complex medical issues going on. And so, yeah, I would definitely agree with everything Dr. Myers was saying.
Jordan, you share with us how trauma relates to persons experiencing homelessness. Is it trauma finding, is it trauma that creates the homelessness, or just explain to us how that relates to a person who's experiencing homelessness?
Sure, absolutely. So I predominantly work with individuals who are homeless and also have acute behavioral health concerns. And there is a huge component of trauma, previous trauma tied to behavioral health concerns and psychotic breaks, kind of a predisposition for mental health plus stressors. So the majority of individuals who have behavioral health concerns have some type of trauma, whether it be, you know, Dr. Myers alluded to some of it, childhood sexual trauma, you know, violence in the home, intergenerational poverty. So a lot of our individuals have experienced some form of trauma, and then generally homelessness in and of itself can be very traumatic. If you already have, you know, a pre-existing behavioral health concern, the stress of living on the streets tends to exacerbate that issue. So stress is tied acutely to, you know, an acute psychiatric response. So individuals talk about, you know, whether it be in shelter or in an encampment or sleeping outside, you're always on alert. You feel like you have to watch your back for safety. If you're in the shelter, you know, people have talked about, I feel like I need to watch my belongings. I don't get a good night rest because I'm with, you know, 200 other people in a shelter. It's unnerving. That exacerbates those behavioral health symptoms. So, and in and of itself, kind of navigating homelessness is traumatic. You know, you're living day in and day to day on a, you know, on high alert. And so it's stressful, it's traumatic, and a lot of our individuals with behavioral health concerns have kind of a long history of trauma.
Is the trauma first or is the homelessness first? I mean, it sounds to me like based on the condition of homelessness, one would, that unto itself is traumatic.
Mm-hmm. Yeah, so kind of echoing Dr. Myers both. So like I had talked about, a lot of childhood trauma leads to behavioral health concerns and homelessness, but also being homeless is traumatic. So it's, you know, pre-existing trauma as well as, you know, daily trauma.
Leah, your clients are veterans who are experiencing homelessness. What are the reasons veterans become homeless? Are they experiencing trauma? What are their needs? How are their needs and issues different from those who are not veterans?
Right. It's interesting because I've had people, you know, say, well, you help homeless veterans. Why shouldn't the VA fix that? Well, why isn't the VA, you know, doing more? So it's hard because you know, a lot of times folks that are veterans have military experience do have you know, all of the same struggles, you know, as folks who are non-veterans, whether, you know, they have mental health, co-occurring disorders, you know, childhood traumas. A lot of them, you know, do have the same challenges, but in terms of compounding that, a lot of folks, you know, if they do go into service, it's typically at either a younger age or, you know, that might be really their only option. So then when they return back from military duty or service, they might not have a lot of the resources. You know, obviously going into military is very punishing on your body as well as psychiatrically, emotionally. You might lose a lot of ties. A lot of the things that you did as your military occupational specialty might not transfer into the civilian sector. So, you know, if you get back, you might, you know, have all of these things going on, you know, not able to get a job, not having the family support, and things just kind of keep snowballing. So, you know, the VA does have a lot of, you know, services, which is great, and they're, you know, very robust and coming, especially, you know, we're fortunate in the DC area to have that. But, you know, again, you know, you'll have folks where you know, it's particularly challenging to maintain and to kind of rebuild that stability. So.
Dr. Myers, what are persons experiencing homelessness most likely, when are they most likely to seek care? Is it, and counseling, is it as someone in a housed group would when they have the first indications, or is this something that often the person waits until it's critical for them to seek care?
That's a fantastic question. I think there's a few layers to that. The first is, you know, I work in overall still a primary care setting. So a fair amount of our patients are, not our patients, but the homeless population, a fair amount of them are presenting to the emergency room when it is an emergency. Hopefully, if they come across a fantastic social worker, might get discharged to Christ House instead of to a shelter from having been hospitalized. But sometimes there is a certain bouncing between the hospital and the street or the shelter. A certain number of our patients have lower trust based on experiences that they've been through. It's not uncommon for us to see patients and for weeks or months, the most they'll accept is like Tylenol or cough syrup. And all of a sudden they'll start disclosing like some pretty significant medical issues that they hadn't let us evaluated. Sometimes they just want to talk with us. We have one gentleman, I've seen him at McPherson Square, this older gentleman, and he would just want to talk about what he'd read in the newspaper for months. And he finally came in for a buildup of wax in his ears. His first medical visit with us. He won't let us check his blood pressure. God knows what it is. But sometimes it is this sort of a dance where there are some barriers to care that we can't see. Like we're out there, we're telling people we're a clinic, our doors are open, we have walk-in spots at our main homeless clinic down in the basement of the CCNV shelter. But there's certainly, it certainly is harder than average for many reasons. One of my patients who comes to our clinic fairly frequently, he needed to get specialty care at one of the local hospitals. And he ran into trouble with the security to get in there because he did not have an up-to-date ID. And he almost got turned away from an appointment that we had worked for months to get him. And in the end, they let him in with a warning not to do it again. So he skipped his follow-up appointment because they told him not to do that again, because it's really not straightforward, especially now with COVID when the DMV is like unclear if they're really open. There's just so many barriers. We don't charge copays at our clinic, but for a lot of patients, sometimes they have $1 or $20 and sometimes they don't. So they really have to weigh it against a lot of their other daily needs of what needs they're going to meet if they are going to seek medical care.
I was going to say that skepticism seems to track with what has been experienced with the pandemic. My understanding is that the homeless population in the District of Columbia is 80% African American and brown persons who are Black and brown. And traditionally, in these communities, medical care has not always been fair, equitable, or competent. And so I can imagine that with someone who is, let's say, 40 or 50, if they've come from an environment where they've experienced that, they would be hesitant. How do you overcome that? Jordan, do you have the same kinds of experiences with care?
Yeah, and I think our population is, about 34%, according to the last point in time count, is individuals who also have behavioral health concerns. So if you already have people who are suspicious of the system or have, inequitable access to resources, now you have a additional behavioral health component on it. So a lot of the individuals in that 34% are people who have acute psychosis. So maybe schizophrenia or bipolar disorder. So now you have, I've had an experience where I've been turned away from a clinic. I've had, an experience where I couldn't get access to that, but maybe now I'm attributing that to people being against me. And so that paranoia is another complicating factor, because it's not just that there was, inequitable access to the system, but somebody's out to get me. And that's why. So I'm not even going to try again. So a lot of what is effective is really doing consistent outreach. And as Dr. Meyer said, sometimes that's, I go out and I, sit with you and I have a cup of coffee and we don't talk about any behavioral health. We don't talk about anything. And maybe at this point, I know your name is Joe and that's it, because you're not going to give me anything else. So it's really about relationship building and connecting with people to earn that trust and move people forward in their goals, and really to help them identify goals that maybe they didn't know they had. You don't know you have a behavioral health condition, or you don't know you have any medical condition because you haven't been to the doctor in years. So it's really consistent outreach and engagement and developing that relationship that gets people connected to services and overcoming that barrier and that complex behavioral health concern as well.
Jordan, when you are able to connect and build that relationship, are you able to get an individual into a treatment plan, or are they resistant?
It depends on the individual. So some individuals are very receptive when you engage them, and some individuals, it takes months, years really to get them to buy into that system. We have individuals we encounter on outreach who are, this is my diagnosis, this is what's going on, I want support, I want somebody to help me get housing. And then we have individuals who don't really have insight into the fact that maybe this is not reality and it's reality for them. So then it's all about very creative strategies to get people to figure out what their goals are and then align their goals with, progress in treatment.
Okay. Leah, are you experiencing the same kinds of resistance at times, or are veterans a little more responsive and to their needs for care?
No, I mean, absolutely. We see that on the VA side as well. You know, I might even say that we might even see a little bit more, you know, from my experience, you know, being in outreach at the VA. A lot of folks, you know, make a point to stay clear of the different community shelters or services because of, you know, past, you know, mistrust. They don't feel comfortable. You know, they had either one or two bad experiences. So it really takes a lot of progressive engagement to kind of, you know, earn that, you know, that trust. I mean, you could have someone that will meet with person A 5 times and then they'll meet with person B and, you know, something will click. You know, the right provider, and they'll really slowly start to engage. Um, but we absolutely do see that from our end. You know, especially we'll have folks, you know, coming, you know, kind of hopping from one VA to different VAs. So, you know, if folks are really sick, you know, we'll try and pull up their information, and it's kind of okay. Well, we see this pattern, we see, you know, all of these things going on. You know, what can we do to even start getting that process moving a little bit?
Dante, what are the differences in the length of hospital stays and recuperative stays for persons experiencing homelessness compared to an individual who is housed, as an example? Are they different?
Yeah, I'm actually not sure about like comparing that to individuals who have housing. I know for our patients, you know, the average length of stay at Christ House is about 40 days. And we've been
Wow.
seeing that be a little bit longer during the pandemic just because we have more resources. And, you know, during this time, we're not really getting the same volume of patients right now. And so we're able to keep the guys a little bit longer. But the average stay at Christ House is about 40 days. And what that looks like is, you know, when they first get to Christ House, they're going to have an intake with one of the nurse practitioners or physicians at Christ House. They're going to go through and, you know, address the chief complaint that they're presenting with, whether that be they're coming back from surgery or they have a big wound, like I was talking about earlier. But then throughout that length of stay, in addition to stabilizing them medically and addressing that main acute medical need, the providers at Christ House are also managing their chronic illness and managing their other medical conditions that are going on and getting them set up with specialty appointments and caseworkers, and our case management team will work with them to, you know, if they don't have insurance, get them onto insurance, if, you know, and connect them with different resources, you know, like the other panelists were saying, to align with what their goals are as, you know, a patient at Christ House. So yeah.
Are there any models that seem to work better than others? I've heard trauma-informed care, housing first. What are the models to care for persons who are experiencing homelessness that seem to work and be most effective? Anybody can answer that one.
I'd love to jump in on this one. Housing. The health issues that lead to homelessness, sometimes they can be addressed from housing, sometimes they can't. But many health issues that come from homelessness absolutely can be addressed. My understanding is that earlier in the series, Dr. Catherine Crossland and Dina Hassan were speaking about COVID responses for people with homelessness, both two really fantastic women who've done a huge amount. And one thing we found when we ran the data for our patients who were housed in the protective hotels for older and medically vulnerable individuals, we saw these just amazing results that their blood sugars improved, their blood pressure improved. We see that when people are homeless, they're like 3 times as likely to have uncontrolled diabetes. They're much more likely to have uncontrolled blood sugars, uncontrolled HIV. severe heart disease. And we saw those numbers. We in real time watched them reverse for patients. We watched the average blood pressures come down as people were housed. They weren't even getting better food. They were getting the same really subpar food that's given at the shelters. There weren't more doctors involved. We just pulled our medical teams from the shelters and shifted them to the hotel. Literally all that changed was that they were housed, and we were already seeing,
Wow.
first off, they're not homeless anymore. But second, we watched their health start to improve in real time.
That's amazing. That's amazing. Dante, once you have an individual at Christ House, are you seeing the same kind of responses?
Certainly, 110%. I mean, that is, I mean, when you think about it, like that, not having a place to sleep at night and being unhoused is one of the biggest stressors that a person could ever experience. And we know that when you're experiencing that huge amount of stress, that's not just impacting you like psychologically. There are lots of stress hormones and other things that are medically going on with your body and impacting you from a medical standpoint. And so it makes perfect sense that as soon as you fix that problem, you see all these other great benefits as well.
That's amazing. It just goes back to saying that if we had more housing for individuals, then it sounds like we would have fewer medical problems. Is that an accurate statement?
Absolutely.
Leah?
Homelessness makes people sick.
Wow. Leah, is that also true for veterans?
Yeah, I mean, absolutely. I think, even though we kind of come from different backgrounds and specialties, the one thing that, I mean, if I'm able to, kind of speak for everyone, really at our core is the concept of housing first. So, I mean, taking back before where it's like, well, in order for you to get housing, you need to be, clean and sober of substances. You need to be on all of your medications. You need to be, active in psychiatric treatment. Whereas now, which, has been for many years rolled out from HUD, actually, the Housing and Urban Development, whereas, the model really is you put an individual into housing first and implement those harm reduction, trauma-informed services and supports. And that's really, where all of us are seeing the trend. You get the person into housing, get them stable, and then, we'll work on all of these other things where they're in that safe psychiatric and physical space to really get those addressed.
With housing, there's transitional housing, there's permanent housing. Is it more effective to start with transitional housing? What is the pattern that works the best to improve the physical and mental health of individuals? Dante, you want to try that one for me? Answer that.
Yeah, I mean, I can't say I have enough expertise necessarily. I think someone else might be better able, but at least from what I can speak a little bit to how like a facility such as Christ House would fit into that paradigm is, the niche that we're trying to serve at Christ House is filling that gap between a hospitalization and acute medical need and the next step for that individual. And we know that, if you've just had surgery, or if you have a big wound, or if you have cancer and you're going to chemotherapy, if you are then going from those appointments and on the street, like that's not a safe or clean or good environment to be healing in. And so Christ House, we're working to provide that environment for them to be able to heal in. And then our case management team works with the individuals, but also most of the individuals who are coming to Christ House also have case managers from core service agencies elsewhere in Washington, D.C. And so they're also collaborating with the individuals' other caseworkers to figure out what those next steps look like, whether that's transitioning to another respite facility, such as AmeriHealth, one of the insurance companies in DC, has a respite facility that some of our guys go to. Or whether that looks like starting to look into what a permanent housing solution might look like.
How many of your patients would you say as a percent that go from Christ House into some form of housing that is either transitional or is toward permanent housing?
This is a rough guesstimate. I'd say maybe like 2/3. But most of it's transitional. Most of it looks like, our case managers are able to reach out to a relative and they end up being able, the relative's like, yeah, they can come stay with me for a little bit, or a friend, or they might be going into another respite facility or something like that. And then our guys who are going into a more permanent housing solution, that's almost always our guys who are going into like a nursing facility. We definitely serve an older population at Christ House. Most of our patients are over the age of 55. And so for a lot of our patients, case management starts working on potentially getting them a placement at a nursing facility.
Okay. Are your patients, Dante, mostly medically have medical issues, or do they both have psychological and medical issues?
Yeah, 70, again, that percentage, 75% of our patients have a psychiatric illness as well, but
Okay.
actively they have to have something medical going on to be able to be at Christ House.
Okay.
Yeah.
What obstacles do the persons who are experiencing homelessness, what obstacles do they have to getting the kind of care that they need?
So I think it depends on the individual, but generally there are some systematic obstacles, especially if you're homeless and you don't have a source of income. You have to figure out how to make your way across town to appointments. I always talk about homelessness as kind of a series of difficult choices. So I stay in shelter. The shelter puts me out at 6 a.m. So do I go to the meal program, if I'm employable, or do I go look for employment? I want to make sure I'm getting my basic needs met. So I can go to a day program and wait, sign up for the list and get my laundry done, or, I have to go across town and recertify for food stamps. So transportation, DC has a pretty good transportation system as it relates to basic needs. So from shelter, somebody can go to a day center and get food and get their laundry done and shower and all of that. But if you have external things that you need to take care of, whether it be recertifying food stamps or, going to a medical appointment or making it to your core service agency, which is a mental health treatment agency, you have to figure out how to navigate that system. So a lot of people have, just challenges getting around in order to meet those needs.
But what about those who are in encampments? They don't have the same resources as somebody that's living in a shelter. Is that correct, Sarah?
That's a little hard to say. I guess it depends on how you define resources. Most of the shelters will provide at least limited access to food, maybe like a breakfast or dinner or both, usually not all the meals. So that is one resource. And then like showers and bathrooms, certainly. We do see in the encampments that sometimes there are pretty tight social networks of people really looking out for each other. And that's something that can really carry over and really protect people. And sometimes losing that can almost be a little tricky part of a transition out of homelessness, that the system doesn't always let people go with a buddy or two, that buddy may be the person who sprays them with Narcan if they overdose, for example, who could save their life. So I do think in general, our patients in the encampments, our clients in the encampments, they are much more vulnerable. We see that they on average die several years younger than patients who live in shelters, who themselves die more than 10 years younger than average. So we certainly see more exposure injuries. We see some trench foot where basically the feet are wet for so long that the skin just gets just all like macerated and kind of bacteria and fungus in there. Some degree of like frostbite injuries, more assaults, traumas, motor vehicle collisions and incidents, things like that. So I think I don't want to gloss over the strengths of the folks in the encampments, but it is an incredibly vulnerable population.
Okay.
I just wanna touch, and but I guess would be curious if Sarah and Jordan have been seeing this as well. There are a fair amount of individuals in our veteran system where they are very adamant about refusing permanent housing. For one reason or another. And a lot of those we've seen is that exactly how Dr. Myers was referring, where they don't have those social supports. If you have someone that has been marginalized, and most of what they know and what they're comfortable with is being in this encampment, being in this shelter system, and that's what they're comfortable. There's a veteran that, in the VA, it's been over 10 years, and he adamantly is refusing because he, will say that he has his group where if he does have medical issues, they will look out for him and they will make sure that he's stable. And they've heard that if you do go into your apartment, who's going to be there with you? Like who's going to make sure you keep, tabs on everything. So we've had people where, it's not limited to the veteran population, but we do have a fair amount of people that will be very clear about, I'm not comfortable with permanent housing. Now, can you maybe inch them along of like, okay, well, let's focus on getting your medical appointments. Are you open to transitional housing? Kind of gauging their level of change, their readiness. But we've absolutely seen that, and I'm almost positive that other folks have seen that in their single system as well.
One of our attendees wants to know, although substance abuse and other psychiatric illnesses are notoriously comorbid, the treatment facilities and options for these comorbidities are often not well integrated. Are there any examples in DC for effective integrations of these to treat these illnesses?
So they actually are relatively well integrated. So you can think of, treating, because often people use medication to or use substances to medicate psychiatric illness. So you think of facilities like PIW, where there's a focus on detox. They have a detox unit, but they also have psychiatrists. They have medical or mental health providers. There's RAP services, which have detox and treatment, but they have licensed clinicians on scene. They have nurse practitioners. They have psychiatrists who also try to integrate care. One of the ways that there is a little bit of a barrier is, there's regulations around HIPAA about what can be shared. So for those individuals who are willing to say, yes, I want my provider to talk to this other provider, those two systems can talk together. But in the last 5 years, a lot of the services have become integrated. There are, MBI has the outpatient behavioral health clinic, as well as the outpatient substance use clinic, and the two go hand in hand. So in the last 5 to 10 years, they've really tried to integrate all healthcare services, including medical healthcare, so health homes, things like that. So trying to take a more integrated approach for that reason, because historically there were kind of silos, but the service providers have really integrated behavioral health services into their substance use treatment.
Does the individual have to also give permission, or is this something that based on your being a medical provider or a provider for mental illness, are you able to share that information directly, or do you have to wait for the patient to say, yes, you can share it?
So it depends on the provider, but if you're an integrated provider, you sign like consent to treatment when you go in. And those are normally umbrella consent forms, which mean that the provider for, you're an integrated provider, so you're providing substance use and mental health. So the two are simultaneous. But if you're going into treatment with one provider and you already have a behavioral health provider, you can consent to have them communicate.
Okay. Dante, are you finding that is helpful for the persons that Christ House receives?
Yeah, certainly. I mean, almost all of our 2/3 of our guys are recovering from substance abuse of some kind. And so we have integrated substance abuse treatment into our programming as well. We have AA meetings that the men can attend, as well as our own substance use program that is called New Day. And we have a dedicated addictions counselor who's a full-time member of the Christ House staff, who's available for both the group setting and individual counseling if the patients want that as well. And then we also have one where we are a part of Unity Healthcare, the same organization that Dr. Myers works in. And we have a psychiatrist from Unity Healthcare who is kind of like assigned to us and meets with all of our guys as well. And so, we are also looking at the entire picture in more of a holistic manner than it might have been done 20 or 30 years ago or 40 years ago.
One of the questions that I have is, how do you measure success when you're treating these comorbidities and you've got a breadth of services that are needed, and individuals also are without permanent housing or unsheltered? How do you manage to know when you have actually been successful with an individual? Anybody can answer that.
So I'm going to, go ahead, Dr. Myers.
Well, I think sometimes your patients let you know how it's going, that they're feeling a lot better, or they're not feeling a lot better, or they keep coming back, or they don't come back. I think what is success in the medical field, many of our patients, especially for those of us dealing with chronic disease management, are going to have those illnesses fairly long term. So it's not like, oh, I gave you antibiotics, I cured you, and everything's better and you're all fixed. But if we do see people on a path towards living a longer life with more brain cells and kidney cells and little cells in their heart doing better, we do see folks really improve and turn around. We see folks with AIDS going back to having functional immune systems sometimes. It's a mix, and sometimes I think it's just about being present with people. That some days I think success is that someone came in and could unburden themselves to you and was able to talk to another human being about what they're going through, and maybe you couldn't fix it, you could just be there with them that day.
Yeah, I agree. Piggybacking off that a little bit, it's individualistic. We have individuals who maybe have, negative behavioral health symptoms, which means that they have a lot of issues addressing ADL because they just lack motivation. So for those individuals, sometimes just showering is successful. And, so it's depending on where that individual starts and what steps they've made are kind of defining success on a very individual level, because, we've had our team celebrate somebody showering and actually successfully, navigating those basic need resources.
I think we have talked about the processes and some of the services, but are there any individual stories that you would like to share with our audience about persons that have been clients of yours that put a positive face? Sometimes I think we look at persons who are unsheltered and we have a stereotype in our minds. Can you share anything that we should know that we as neighbors might not understand.
This is a favorite topic of mine, so I'll jump in. So one thing about me is that before medical school, I did a year of AmeriCorps service with Unity Healthcare's Healthcare for the Homeless team, somewhat similarly to what Dante is doing now. And one thing that struck me, but I continue to see, but struck me then and keeps striking me again, is just generosity that I've seen among people who are homeless. That the first time I saw it, we had a patient who didn't have $1 for the Medicaid copay for their medications. And the nurse who usually helped try to apply for copay waivers wasn't there that day. And the patient just said, I don't know what I'm going to do. And a perfect stranger in the waiting room pulled out a handful of crumpled dollars from his pocket and was just like, here you go, miss, and just gave her one of his dollars. And I don't think he had that many dollars to give. I think proportionally what he gave was probably a higher proportion of charity than any of us have given in our lives. And then a few weeks ago on our homeless outreach van at McPherson Square, it was sort of funny as it was happening, but also just incredibly touching. We had, I called it the fight over the ibuprofen. We had one bottle of extra strength ibuprofen left. We usually have a small amount of medications to give out. And two of our patients both came in with aches and pains, and they had a fight over the ibuprofen, each trying to give it to the other, each one insisting, oh, Mr. So-and-so, if Dr. Myers said you need it, then you must need it. Oh, Miss So-and-so, I know your back hurts you. I insist you take it. I'm feeling fine right now. And they went back and forth for 2 or 3 minutes until finally Mr. So-and-so just put it in the hands of the other lady and was like, I insist. Like that sort of thing where you think that people would be, I don't know, there's this idea that there's this Lord of the Flies thing, but it's really, that's not who people are, even in really tough circumstances. You really just see some incredible kindness and connection and generosity come out.
What about you, Jordan? You have any experiences?
Yeah, I always like to kind of, when I talk about people experiencing homelessness, particularly with behavioral health concerns, is there's no one face for homelessness. Our team has engaged a Harvard educated lawyer who had his first psychotic break after becoming a lawyer and in trial, and is, sleeping outside. And we would go and engage him and try to make sure he was warm, and he could explain the physics of like convection and why the cold was sucking the heat out of him. But, it would take lots of coaxing in order to actually cover him. And I think one particular story that's always stood out to me, particularly because, individuals will encounter people who maybe have substance use addiction and maybe come with their own assumptions. And we met an individual who is in her 20s to 30s and really got to know her, obviously was battling very acute addiction. And when you started to unravel her story, she was in her final years of med school when her mother died. And her mother was like her primary source of support. And she took a semester off. And I think the grief she wasn't able to kind of process, because that had been her primary support for a long time, and ended up homeless because she wasn't in school anymore, and she didn't have her student aid. And so we encountered her in an encampment, and she was actively battling addiction, and just kind of been working with her around complicated grief and coping mechanisms, and also now working towards substance use treatment, because not only is there the trauma and grief of losing a mother and dealing with that, but also now I'm actively addicted physiologically to a substance, to working through that. Particularly because I think with substance use, sometimes people are like, oh, this person's just an addict, but looking at the story behind that with some compassion.
Okay. Leah, what about any situations that you want to share?
I feel like it's a little bit tough for me because I'm like kind of the front door of VA homeless outreach. So I don't really have a lot of like opportunity, but in that there have been a couple instances that stick out where veterans will be coming in and using our facilities to like shower and laundry, and we'll try to outreach them. There are times where they're like, oh, I'm not eligible for housing because I'm not a combat vet. or they're like, I'm not eligible because I upset my commanding officer and I have a general under honorable conditions. So all these kind of loopholes that they've been told X, Y, and Z is why I don't qualify. So in working with them, we've been able to, find our, our own loopholes and really get them connected with either transitional and oftentimes permanent housing. So those are oftentimes folks that will, again, not feel comfortable, accessing the shelter, but will just be coming in once in a while to shower and do laundry at our facility. But that's the only VA that, our VA clinic's the only one they're comfortable with. So they'll drop in and again, just good engagement, talking to people like they're people, and that's usually enough. So yeah.
Dante, quickly, do you have anything else? We're almost out of time. Is there anything else that you can share, that a story that you want to talk about?
Yeah, I wouldn't say I have a specific example. It's more generalized, but kind of what Leah was just talking about. I love just like interacting with the men and just talking with them and engaging with them. And a lot of the times, it's just a simple conversation about the weather or sports, or sometimes they'll open up to you and they want to share more about their story and where they're coming from. And every time, like, either they express it or like you can just tell like they're so grateful to just have someone else to talk with, like normal, like, nothing else is going on and you're just talking with them like another person, and that is always, and I've had it, expressed many times, like, thank you so much. Like, it feels so good to have someone to talk to. But a lot of the times it's just kind of implied. And that's been one of the most amazing parts of this year, serving at Christ House.
Well, I want to thank each of you for participating in our panel. Our goal this evening was to place a different face on individuals experiencing homelessness, and our panel really accomplished that. Per healthcare.gov, a website for the Affordable Care Act, a broken leg can cost $7,500, and the average cost of a 3-day hospital stay is $30,000. In summary, we learned that homelessness is often the result of trauma, job loss, and/or illness. In the US, most bankruptcies are caused by insurance or financial burdens, burdens for medical costs and expenses, and/or job loss. The pandemic exposed the inequities in healthcare. There is inequity among individuals who are homeless, as 80% of persons experiencing homeless in DC are Black or brown. And that homelessness does not result from laziness or a lack of initiative, but most often it is the result of trauma, job loss, or illness. By the way, illness is the #1 cause for bankruptcies in the United States. But if you are an hourly worker, you may not have that as an alternative. The plight of individuals experiencing chronic homelessness is complicated, but it is compounded by a lack of housing, priced for someone earning minimum wage of $15 an hour, which amounts to only $31,000 annually. And only $5 per hour is the minimum wage for DC tip earners. A person earning minimum wage cannot afford to live in DC. Per the February Zumper DC metro area report, the median rent for a 1-bedroom apartment in DC is $1,960. In DC, rental vouchers average $1,500 or $18,000 annually. Based upon my math, it would be much more cost effective as well as humane to provide housing. And based on our panelist discussion this evening, that is the first step to taking individuals who are homeless and returning them to contributing citizens and improving their health. Thank you so much for this evening. I hope all of our guests have learned a great deal. I sincerely appreciate your being on our panel this evening. Thank you so, so very much.
Diane, thank you. And just good evening all. I'm Nick Manning, and I've been coordinating the DuPont Circle Citizens Association Homelessness Committee for the last few months. And it's been great to be part of this event tonight and to learn from this tremendous panel. So let me begin by thanking them. Dante, Sarah, Jordan, Leah, thanks a million. You've done a great job. And also thank you, Diane, for working so hard to pull this evening's discussion together. And also just to thank Erica and Glenn, who behind the scenes have managed the techniques, and thank also all the members of the DCCA Homelessness Committee. Just a little about the series that we're running through here. This has been the third in a 6-session series, so we're halfway through. And the basis of the series is that we don't know the best way forward, but we do know that what's happening right now is either not optimal or not enough, or likely both. So tonight has underscored that it's not all about money. It's also about service, kindness, family, illness, trauma, and luck. But let's be clear that limited resources are a binding constraint. Homelessness is a multidimensional issue, and sometimes people don't want housing that's on offer. But as Diane has reminded us, homelessness is never not about the lack of a home. So our idea in putting on this series is to provide information and informed views so that as neighbours, we're all in a better position to make our own decisions about how best to help, how best to campaign for change. DC has achieved a lot in addressing family homelessness, and we've heard tonight about some progress in service provision and service coordination for single unhoused people. But however you cut it, DC's level of homelessness for single people represents a shameful failure in civic governance and an obvious tragedy. Now, just let me provide just a very quick run through of where we're at in this series of 6 events. So for the first session, we kicked off by looking at what additional difficulties, what further trauma COVID-19 has added to the lives of people experiencing homelessness. The second session looked at some of the roots of homelessness, the arithmetic of the need for affordable housing and its availability. Tonight, we've been talking about psychological challenges, substance abuse, and we've heard that cause and effect is a conundrum. There's a higher incidence of such needs amongst people experiencing homelessness, but homelessness in itself has severe psychological consequences. Next week, on March the 11th, we're going to review the importance of permanent supportive housing in moving people from sidewalks to safe homes where they can rebuild their lives. So that means homes that are more than just bricks and mortar, homes that offer real support. Then on March the 18th, we'll look at policy in DC and whether recent approaches have been successful in addressing homelessness and increasing the availability of affordable housing. What would it really take? When politicians throw numbers around, when they say we've spent X million dollars on this or a further Y million dollars on that, how should we think about the scale and effectiveness of that spending? And then we'll conclude the series on March the 25th by hearing about the experiences of LGBTQ youth and of women who've experienced homelessness, looking at the very particular challenges that they face. So to emphasize, our purpose in this series is to help all of us as neighbours reach informed views about where we can and should go from here. Thanks again to all of you, and we hope that we'll see you all next week on March the 11th. Thank you so much.
Thank you.